Welcome everyone to our quarterly SOAR webinar series. Today's talk will be on quality improvement strategies for promoting vaginal birth. A couple of quick logistics before we get started. Please note this call is being recorded. I've given you all the ability to talk, but please stay muted during the presentation. That said, there's a Q&A tab, so please, if you have questions, type those into the Q&A. And then we held time at the end for discussion about this topic. And then lastly, we have an evaluation survey that will pop up after the call. Please complete that to help us improve these webinars for you in the future. So as I mentioned, today we're going to talk about quality improvement strategies. We have Dr. Stefka Fabry from Denver Health. We have Sarah Scott, who's a certified nurse midwife. We have Amy Dempson, who's the OB clinical practice specialist at Lutheran Medical Center. And we have Courtney Cryer, who's the service line director of women's services for Montrose Memorial Hospital. And then, as I mentioned, after this presentation, we will launch into the discussion. So with that, I will pass it on to
Great. Thank you, Val. Thank you, everybody, for joining us this morning. My name is Stefka Fabry. I'm an OBGYN generalist at Denver Health. And I will start today's webinar by just briefly reviewing basic patient safety and quality improvement topics. And we'll start off by hopefully answering the questions, why do we care and what can we do about it? Will you advance the slide? So this has been in the news quite a bit over the past year, and unfortunately, we all know maternal mortality in the US is rising, and it's much higher than in other developed countries. Next slide. When it comes to NTSV cesarean rates, even though Colorado is one of the states with lower NTSV cesarean rates, we have been seeing an increase over the past decades and over the past few years. Next slide. So how do we go about instituting or starting patient safety quality improvement projects with regard to maternal health and NTSV cesarean? And I think there's three basic principles or concepts. One is the establishment of just culture, the standardization of care, and of course, effective communication. What is just culture? Well, it's one that recognizes that competent professionals, despite best intentions, will make mistakes. It acknowledges that even well-intended deeds and professionals will develop unhealthy norms, and that refers to things like shortcuts or routine rule violations. Or it also has zero tolerance for reckless behavior. So I think a good example would be, you know, the provider who has tantrums in the OR and puts her patient or other staff members at risk. And of course, just culture allows for disclosure, non-judgmental and safe disclosure of errors, including one's own errors. And really, this is the kind of the gold standard of a just culture when providers, the care team, self-reports. Next slide, please. Why do we want to build a just culture? Well, it creates trust within the care team. It promotes a reporting culture. It supports the creation of high reliability organizations. And these are organizations where complexity is very high. Catastrophic errors can happen, but those are anticipated and avoided. And lastly, in a just culture, there's a systemic approach to error reduction. What is the greatest enemy of clinical quality or quality in care? And this is a quote by Edwards Deming, and it is unexplained clinical variation. So why is that there's so much difference? Next slide, please. This is a 2011 data from the American Hospital Association, and they looked at geographic variation in spending per Medicare beneficiary. And I think the pie chart is really quite striking. Even after adjusting for things like health status of the population, wage adjustment, population characteristics such as morbidities, population socioeconomic status, 56% of the variations remained unexplained. In other words, it was due to patient preference, provider preference, differences in practice that were not necessarily warranted. Next slide, please. And this is true for the field of obstetrics and gynecology and maternal and infant health as well. This is CDC data from 2019 looking at cesarean delivery rate by state as well as infant mortality rate by state, and you see the striking differences. There's multitude actually of similar examples. A very common one in day-to-day clinical practice, for example, is the diagnosis and treatment of UTI. How do providers go about it? You know, do we obtain? Do we go just based on symptoms of the patient? Do we obtain urinalysis? Do we get urine culture? The choice of antibiotic, the duration of treatment, 3 days, 5 days, 7 days. So even something as simple as the treatment of urinary tract infection has tremendous clinical variation. Next slide, please. Generally, there's two types of clinical variation. One is a necessary one, right? It is required to adjust treatment based on the patient's differing needs. And an example of that, of course, will be things like allergies to medications, interactions between medications, renal functions for dosing, things of that nature. But there's also unexplained clinical variation. And this is what hinders quality in care. Unexplained clinical variation is a difference in medical care and patient management that are not accounted for by differences in patient symptoms or objective findings. Why does unexplained variation happen? Well, there's a lot of reasons. Medicine is becoming increasingly complex. I think many of us, probably most, have seen that clinical knowledge and studies are increasing exponentially, and it's really hard to keep up with all the new things that are coming out. Another example here is the availability of antibiotics. So 100 years ago, we had penicillin, and that was it. And now there are more than 100 different types of antibiotics. So it's hard to keep up with all of that knowledge. Sometimes there's lack of valid clinical knowledge, poor evidence for certain practices, reliance on subjective judgment is another reason. And this is where the notion of the art of medicine comes in. You know, how much is really art and how much should be evidence-based? Of course, there's human errors as well as gaps in systems that lead to unexplained variation. There's enthusiasm for unproven methods. Sometimes we go by the notion that if it might work, let's just do it. And of course, the notion that quality equals the newest, the most expensive method, and we should not spare any expense. And the graph on the right side, the test this. This was it looked between the association of annual Medicare spending per enrollee and overall quality ranking of healthcare, and you can see that those are actually inversely related. So spending more money does not necessarily mean higher quality. Next slide, please. Thank you. What do we do about unexplained variation? And I think the biggest thing here is standardization of care. And this is done through evidence-based medicine, establishing clinical guidelines, disease registries, clinical reminder systems, especially now that we have electronic medical records. So reminders for routine screening services, for immunizations, notification if there's elevated blood pressure in pregnancy, things like this. And then, of course, providing actionable feedback to providers. And the last part in patient safety and quality, or another important notion, is, of course, communication. We know that it is a critical component of quality of care and patient safety, and that effective communication increases patient and provider satisfaction. It improves adherence to treatment plans. It helps with appropriate medical decision-making, and of course, improves outcomes. With that said, how to go about effective communication, it's a huge topic. The one thing that I think I would like to point out is communication. How we go about communicating depends on who we're talking to. And here, there's really interesting work on different, how to communicate with different generations. I like this cartoon because it summarizes it well. And I think we've all run into this when talking to senior members of the care team versus new graduates. You know, do we write a long, several paragraph email or even a letter, or do we just send a very brief 2-line message? Next slide, please. And lastly, you know, how do we go about changing practice? How do we go about starting a quality improvement initiative? We do need to create a shared vision and mission. This is always a team effort and not a one-person battle. One needs to develop broad cross-sectional support, and that includes not just from the care team, but also management, administration, and so forth. We should choose projects that are practical, achievable, and make a difference. We should provide feedback and celebrate early successes to motivate the initiatives and participants. And lastly, it is important to start with early adapters. The graph on the right side shows the bell curve of diffusion of innovation. And we have the small percent of people who are really excited and are going to take it on. Then there's the early adapters who are going to stand behind you and support you. And it's really these people that we need to integrate into our initiatives early on to make any project successful. And I think that is all I have. I think Sarah will turn it over to you. Thank you.
Thank you, Stefka. Yeah, so I'm going to talk about today a few tools that we can use to start to make the model of improvement. And then it's a little bit backwards, but then after that, I'm going to talk about ways to identify what your goals that you want to identify, or ways to statistically identify the goals that you want to improve upon. So we start here. I think most of us have probably seen the SMART goals acronym, and just to briefly go over the S is for specific. You want to have a very specific purpose. If the goal isn't really specific, it's gonna be impossible to kind of get going from the beginning. Measurable. You want to make sure you can measure your goal so that you'll be able to tell if it was met successfully or not, because we can't really set a goal if we can't measure it. Achievable. There needs to be kind of a sweet spot for your goals. Your goal can't be too easy, but it can't be too difficult. It needs to make you, in lack of a better word, break a light sweat and motivate yourself, but also not to fill you with despair for it being unattainable. Relevant is the R. Goal setting itself is not enough. You have to make sure that the goals are relevant to the people that will utilize them and that will benefit from them. And then, of course, they also must align with your organizational goals and help with organization growth. And then finally is time bound. Goals cannot go on forever without any end in sight. You need to specify the time period during which the goal can be carried out and the objective met. And more importantly, when goals are time bound, they tend to be more motivating to reach that goal. Next slide, thank you. So we've also probably, most of us have seen the Pdsa cycle. It is a model for improvement and typically goes from plan, do, study, act. So once a team has set an aim, established your stakeholders, and developed measures to determine whether a change can be improved upon, the next step is to test a change in the real work setting. So the plan, do, study, act cycle is shorthand for testing a change by planning it, trying it, observing the results, and acting on what is learned. It is basically action-oriented learning. So the first one, of course, plan is to plan the test observation, including a plan for collecting data. So you want to identify your objective of the test, make predictions about what might happen and why, and then develop a plan to test. The who, what, when, where, and what data needs to be collected. And we'll kind of talk about identifying, like I said, the different areas to plan for change here shortly. Step 2 is do. So then you want to try out the test on a small scale. You want to start by carrying the test out with the stakeholders in the group, document the problems and unexpected observations, and then you begin to analyze the data. 3 is for study. We're going to set aside time to analyze the data and study the results. So complete collection of the data, complete analysis of the data, compare the data to your predictions, and then summarize and reflect upon what is learned. And then the final step is act. So refine the change based on what you learned from the test. So determine what modifications should be made to achieve the goal that you intended to set out based upon your small scale cycle, and then prepare a plan for the next test. So before going back to the plan, do, study, act, you want to kind of ask yourself, what are we trying to accomplish? How will we know and measure that the change is occurring and is improving, and what changes can result to improvement. The next slide. Stuff that briefly, not briefly, did a couple of slides about variation, but we have to recognize that some variation occurs naturally in any process. So the difference is common cause and special cause. So common cause variation is the natural, expected, or random variation. So typically, it's what we would normally see in pretty much any sampling of events, and it generates the typical bell-shaped curve with typical standard deviations that we've seen before. But then, as Stefka mentioned, special cause variation is the unexpected, non-random variation that results from unusual occurrences. And it's important to identify and try to eliminate the special cause variation. The out of control points and non-random patterns on a control chart can indicate the presence of special cause variation. That was a lot of statistical talk there, but we'll move on next. So let's talk about tools to identify your areas of improvement. So you can see here on this bell curve, depending upon the criteria identified for improvement. So let's say if you're wanting to evaluate, depending upon what issues your team has identified. So examples would be, what is the dilatation at the time of C-section is called for in PSC, how long have we been pushing, etc. Whatever your data point is, you're going to want to plot those. And when you do so, you should have your bell curve of your 68% of the data point should fall in the middle, and then 95%, sorry, a little bit more, but you're depending upon all your standard deviations, and depending upon your data points, then your outliers can be identified out, and those are the ones that then you can be addressed. So remember that 68% is within the 1 standard deviation of the mean, 95% is within 2 standard deviations, and 99.7. So look at the outliers, and that usually will identify some topics or some areas to focus on. Next. Okay, so then a run chart, this is just another way of plotting out your data points to try to determine the outliers. So a run chart is a graph of data over time, and then it's a really simple and effective tool that helps your team determine whether or not the changes you're making are actually leading to improvement. So run charts do help the team identify aims by depicting how well or how poorly a process is performing, and understand the value of the particular change, and then also begin to distinguish between common and special causes of variation. So for a run chart, you want to obtain a set of data points in the natural time sequence, establish a vertical and horizontal axes, leaving room on all sides, and then label the vertical axis with what's being measured, aka percent of births by C-section, and then label the horizontal axis, x-axis, with unit of time or sequence. So it could even be by month, it could be by quarter, and then you'll want to plot the data in the sequence in which they occurred, and then draw lines to kind of help connect your data points. So this, by plotting out, you'll be able to calculate the median of your numbers and draw that kind of line as to see where your upper and lower limits are. Next one. And then a control chart is another tool that you can use. It includes an upper control limit and a lower control limit. And it goes a little bit further in helping teams distinguish between common cause of variation and special cause of variation within a specific process. So you would want to use a control chart when you have more than 15 data points and you would want more insight into your data. So the control chart really helps identify early signs of success in an improvement project, as well as monitor a process to ensure it's holding the gains as we continue on. So the difference between a run chart and a control chart is they're kind of the same, but the control chart adds additional parameters. So instead of calculating the median, it would help you to calculate the mean or the control limit, the average, and then allow you to then draw an upper and lower control limit that corresponds to the deviation and the mean, and then that can help you to determine what your outlier cases are to you. So, control of a process. How do we attain control of the process? you want to identify the stable, the in control ones through however many standard deviations you need to, but then also identify the unstable ones, which is the special cause variation. And that's really important to be able to distinguish between the two when you're trying to develop your program for improvement, and that we know that we're hopefully switching the unstable data points over to the more stable. So, fixing the problem, that's cause and effect. What are we trying to solve? We have to identify what we're trying to correct through our different whatever statistical analyses, and you want to look at how we're going to develop, how are we going to identify the areas that we want to focus on, and what are the contributing factors to that. So go ahead and do the next one. So cause and effect diagrams are like our fishbone diagrams. So when you typically look at a diagram or create a diagram like this, you want to identify what your problem statement is, and that you've identified, and that's usually where you would put at the head of the fish, and then you're going to want to develop broad categories of contributing factors. So, for example, it could be staffing issues, it could be shift change, it could be number of interventions, it could be time of day. There's a lot of really broad categories, and then you want to take your outliers and see how they would fit underneath those, and then that would help you to identify which of those broad categories is where you want to start to then develop either your Pdsa cycle and identify your SMART goals to then contribute to your Pdsa cycle. And I think, and then here's an example. Sorry, it's really small here, I can't really see it, but a good example is, again, environment, equipment, method, communication, data gathering, people. And so you can tailor these different, tailor your different situations to be this broad, or it could even be for people, it could be a staffing issue, it could be a provider issues. You can really make them even more specific or more broad, whatever is helpful to your organization. And then I don't know if this was Stefka that added this, or Valerie, but it's an example of a obstetric event debrief form that is used by some teams as more of a way to identify in a specific situation, not in a broad general term, but kind of doing your own review of what happened and what contributed to the situation that you're debriefing about. So this would be something that could be used for a one-off situation, and then that could help to identify maybe the special cause variation. And that's all I have. I'm going to turn it over. I think next is Amy.
Okay, perfect. I just wanted to point out that we don't have to reinvent all of these tools. There's several websites that have all of these tools embedded within, and most of them are at no cost. So the first one is that I pointed out is from Johns Hopkins, and you just Google Johns Hopkins Quality Improvement Resources or Evidence-Based Practice, and this website will come up. And the next slide gives an overview of the Johns Hopkins Nursing Evidence-Based Practice Model. So there are many hospitals that have selected their nursing evidence-based practice model, and it's great to stay aligned with those models that have already been selected, so that you're working within the system and not going against the grain. This happens to be the one that my hospital selected, so I know quite a bit about it. And I love that it's got 3 buckets: practice question, evidence, and translation. And then working within this framework, you can move through a project quite nicely. So the next slide gives a summary of those 3 buckets, and it breaks it down into really specific, tangible steps. So when you're doing an evidence-based practice project, it's helpful. This guides you through each step. And I love that it's so practical and tangible. I also have noticed that in doing evidence-based practice projects, that when you skip a step, it usually comes back later to kind of bite you. And so it's nice to just stay in order and follow this guide. So one example that I wanted to give was the implementation of nitrous oxide. I had years ago, this is several years ago, we had identified this practice question. We had moved forward with creating a guideline. We were looking at how to implement it, and we put together our team, and we were missing a key team player, and that was facilities. And at the when we pulled facilities into the meeting, we learned that we didn't have the correct air quality in our rooms at the time for what the state guideline had set forward, and we had to halt our entire project. And I thought, oh yeah, had we identified the correct team members from the beginning, we wouldn't have moved so far down our process, and we would have known that information ahead of time. So I have since learned that recruiting the multidisciplinary team and identifying the correct team players is really a crucial step. So this works through that practice question process, and then it helps you do your literature search, your review of literature, collate all that information, and then translate that evidence into a tangible plan. So the Johns Hopkins model is a really helpful practical step, and it has on their website, you log in, you create your username, your password, and then all of these tools are free. So everything that Sarah just identified is available on their website, and it's there to use at no cost, which is great. And there are other models out there. The next slide gives an example of the Iowa model. You can see it's in their gold and black colors. This is from the University of Iowa, and it's a very similar model, and also has multiple free resources on their website. And the next one is not through a university, but it's the Institute for Healthcare Improvement, and they also have many of these tools to guide you through a project at no cost. So I wanted to put that out there as another source of resources. And then I also wanted to point out Cotter's change model, which is really, it's not nursing based at all. It's for businesses, but it's a really helpful tool. And Cotter has a website, he has books, and he has multiple resources as well. So his 8-step change model I have found to be very helpful. And each step is very practical. Create a sense of urgency, form a powerful coalition, create a vision for change, communicate that vision, remove obstacles, create short-term wins, build on that change, and anchor the change in corporate culture. And I have found this to be helpful, especially for reducing primary cesarean section rates. The urgency is there in our statistics. So I love that CPCQC is doing that work for us and creating that urgency, making it so tangible, creating your powerful coalition within your own site, creating a vision for change is establishing your rate and what your goal is and where can we get. How do we communicate that vision to all of our team members? Removing obstacles, and that's going to be culture specific. What is the obstacle at each site? Short-term wins, can we break that down? Can we reduce our C-section rates within each of the buckets. For example, okay, can we just look at our rates around fetal intolerance of labor? Can we move that bucket? Can we remove the rate within that group? And then can we look at our failure to descend? Let's just look at that. Let's look at second stage labor management. Let's create some short-term wins within that and then build on that change. And then how do we make this sustainable? I feel like number 8 is the key because sustainability is really where our success lies. For example, the rates at my hospital were significantly lower in 2019 and then went back up in 20. I think we need to go back and look at sustainability. Where did we drop the ball? Where did we lack at anchoring that change into our culture? And so I think this model is really helpful for creating change and sustainability. So those were some of the practical examples. We want to hand it over to Montrose so that they can talk about how they created a culture of change and sustainability within their hospital on this topic. I'll hand it over.
Thank you, Amy. So my name's Courtney, and I was asked to come and share an example of our successes and kind of what we did to implement our SOAR project at our hospital. So I'm just going to tell a little bit about our hospital for those of you that don't know us. Go ahead and go to the next slide, please. So we are a 75-bed rural nonprofit hospital. We're on the western slope of Colorado. We have 4 LDR rooms, 5 postpartum rooms. We are a level 2 nursery, and we deliver approximately 370 babies a year. We obviously, we're a full spectrum. We're an LDRP unit, so that also takes GYNs. We have 4 obstetricians, 2 nurse midwives who are acting as hospitalists basically on our floor now. And we have 7 pediatricians, 1 family practice physician that's doing OB, and about 13, 14 registered nurses, 2 LPNs, a couple CNAs, and then our PRN staff. So just kind of setting, showing you the size of our hospital and where we were starting. So basically, when I started this project and looking into SOAR, as a director, I needed to kind of understand where we were as a hospital, what was our current nulliparous C-section rate, and what did this SOAR project look like? What did it entail? And then comparing us to the Colorado and national benchmarks, looking to see kind of where other people were and placing us on that scale. I was also, once I learned a little bit about SOAR, evaluating our culture, our staff, the way we do things, our practices, and kind of what the SOAR project was offering in the way that maybe other hospitals were doing things differently. And basically that was my starting point. And then I obviously had to, when you're looking at that 8-step of Cotter's change model, that's what we also used in combination with the Pdsa. And I needed to create that urgency. I needed to bring all of our data and where we should be and kind of basically a sales pitch to our docs of, hey, look, here's where we are and here's where we really need to be and here's what other people are doing. And I did this at our OB committee because at our hospital, that's kind of where all of our main stakeholders were. So once I presented that at our committee and kind of got the key stakeholders involved, I got everyone involved. So all 4 of my obstetricians immediately got on board, or midwives, and then kind of had to take that to the nursing staff after I got our providers on board. And our CNO was with me every step of that way. So then once we kind of got everyone on board, we had to talk about what does this look like? What is everybody's roles in this project? And what we determined for our hospital was the obstetricians, they're going to be filling out the dystocia checklist before they even called a primary C-section. The nursing staff, we educated to those guidelines. One of the big things was allowing more time, pushing efforts instead of just calling it sooner. We identified one nurse champion to help kind of enter this data into REDCap so that we were looking at where our rate had started and where our goal was and measuring it along the way to see how we were doing so we could keep evaluating ourselves. We would continuously every month bring those results to OB committee, and we would discuss certain fallouts, and we'd look at strips and talk about charts if some of the docs had a question, or they would bounce ideas off of each other, like, what do you think about this, or what would you have done in this situation? And also, I think a key part for us and our successes was meeting with the Soar coordinators in the very beginning, especially. We would meet every month and talk with the docs that were part of this project. And that would allow my doctors to, again, bounce ideas off and be like, here's what we're doing. It's not really working. How would you tweak this? Or what are you guys doing over there? What are you seeing that's working? Next slide, please. So again, just meeting with the SOAR coordinators, understanding what interventions were being implemented at other hospitals and seeing what we should be doing or what we could change for ours. This is where a lot of education came in for us, kind of like Dr. Stefka had mentioned earlier. There are variations in practices, and even when I look at my providers who have been there for a while compared to, we have a couple of newer ones that are coming out of residency, there's a difference in their practices, and it's great to watch their collaboration and kind of bouncing stuff off of each other and figuring out what works for us and what doesn't work for us. And I know over on the Eastern Slope, you guys had a lot of tools that you gave us, and the way we managed our inductions was a big one. We had to create new policies. We weren't using the Foley bulb or Cook catheters for inductions. We were kind of with the basics, your Pitocin and your Cytotec. So that was a huge help for us. Again, looking at your guidelines, right? Allowing more time to push and finding that balance of not tiring out our moms and our babies, but still giving them more time to offer that vaginal birth and making that happen. Using IUPCs more often, you see a contraction pattern on there, and though you're palpating, it still can be subjective to an extent from one nurse to another. And so we were finding that though we thought they were in a good active labor, their contractions weren't really strong enough. And then taking all of this information after the providers were educated from our docs with SOAR, taking that information and educating the nursing staff and getting them on board and talking about ways that we could help facilitate some of these changes and how we would manage our labors moving forward. Next slide, please. One of the other things that we found too was patient education and starting in the clinic with this. When we would bring in inductions, and we would call it, because it was a failed induction in the past before this project, we would just take them to C-section. And as we kind of worked with the docs in the SOAR program, we kind of started changing that practice and telling our patients, listen, just because we bring you in for induction, if the baby's safe and mom is safe, we might take a break after 2 or 3 days if we're not getting you there, sending you home, and bringing you back a day or two later if it was safe to do so. And we found a big improvement there as well in decreasing our rates. implementing the checklist. We did change our AMA guidelines. So I know ACOG still says 35 years old and 39 weeks to induce. We changed it to 40 and 40. So 40 years old and inducing at 40 weeks. And otherwise, we don't induce anyone else until they're 41 weeks post-dates. We kind of stopped the 39-week social inductions, and that tremendously helped us. Discussing these cases every single month. We had bi-monthly meetings once we got past those monthly meetings to continue keeping up the progress and talking about information and reviewing the data. Next slide, please. Some of our challenges, old habits, kind of like what we talked about, and sustaining that change, it's hard to do. And so not giving enough time. You've got nurses who've been doing this and that's what they're used to. And so that's the way they practice. Not actually measuring our MVUs for contractions and using those IUPCs, not pushing long enough. Nursing for us at a rural hospital, having to change our threshold for the category 2 strips and not calling it right away because we don't have an OR in-house 24/7. So finding that fine balance for us was key. One of the other challenges was the dystocia checklist, the providers remembering to fill it out. In the beginning, they did great, everybody was gung-ho, and then sustaining that and keeping that up was a challenge for us. And then changing the way we managed patients, and because they were still, we would have a few in the beginning who declined to go home after we started their induction. So really working on that education in the clinic was key for us. Next slide, please. So our successes, we made a huge change once we got everybody on board and everybody kind of embraced this project. Embarrassingly enough, we were at 34% in the beginning when we started this. We cut our rate dang near in half within the first year. We went down to 19.9%. That second year, we were at 17%, doing great. And kind of like someone else had mentioned, I think Amy maybe, last year we kind of fell backwards again and went to 24%. So we have gone back and looked at all of our primary C-sections, nulliparous primary C-sections, to kind of figure out, what are we doing differently? Did something change? We had COVID. What does that play into it? Some of those factors. And when we did that in the beginning of the first quarter, we've kind of gotten back on track. And for the first quarter thus far, we're at 14%. So working on sustaining that change again. Next slide. Now we are at that point where I just said we're sustaining that change. So we have decided to continue to meet monthly to review our progress and data OB committee. And so we take a quick 15 minutes to go over this. We are checking in with our providers. I'm asking them, what do we need to do? What are you seeing? What can I do to support you? I know that my providers rely on Dr. Stefka and Sarah and some of these key providers that are part of the SOAR program to help bounce ideas off of them. And as they're coming up with challenges in some of their practices, kind of helping get them towards maybe things that other hospitals are doing. So that's big for my providers. And then bringing all of that information again back to my staff. I have really found that closed loop communication, having conversations with my providers and having conversation with the SOAR team, I really have to keep bringing that back to the staff so that everybody's on the same page. And just continue to talk about it. And then again, celebrating those wins, part of that cottage change managed model. Giving the organization-wide kudos, acknowledging certain individuals as they have successes, and senior leaders are joining in on that and acknowledging our providers and our staff, and so that's made a big difference for us. I've taken the providers out to a quarterly breakfast and lunch to kind of discuss what are their concerns, what do they need, what are their successes, and allowing them to have that hour or two to discuss these cases with each other. So that's where we're at right now to sustain some of these changes.
Thank you so much, Courtney. Lots of kudos in the chat. Montrose has made amazing progress in this project, and that's why we really wanted to bring you in to share those successes and your expertise. So thank you for that. And so we have one question in the chat, and then I will open it up for further discussion. I believe you all have the ability to unmute yourselves and chime in, or you can post things in the chat and I'm happy to read them. So one of the questions that came up for Courtney was, can you tell us more about how your team came to agreement about limiting elective inductions at 39 weeks?
Yeah, so part of when we looked at where we currently were and what our practices were, we had a high social induction rate. And when we looked at why we were going to C-sections, it was failed induction. And so we thought that after discussing with the SOAR team to change our AMA guidelines and our induction practices, because that's where our problem was, that's where our biggest success was. That, honestly, I will say that's our main reason, I believe, for us dropping our rate in half.
So Courtney, when your rate started to go back up again, did that practice change as well?
No, so no, it did not change. Last year during COVID, when I went back and looked at every single case, it was fetal distress for almost all of them. I think I only had maybe a handful of failed inductions, but the majority of them was fetal distress. And so we're kind of at that point like, okay, is that just one of those weird, like we had a run and it is what it is? Because at the end of the day, we still tell our providers, listen, all that matters at the end is a safe mom and safe baby. And so we're going to have those blips sometimes. And as long as we're keeping a finger on it and an eye on it, that's kind of how we feel, to kind of keep on track. So I can't explain why we went up.
Thank you for sharing that.
Absolutely.
And I think that's a really great point. It's really easy to say, well, it's COVID, we just had a weird year. But going back through and doing those case reviews and doing that data analysis really helps you know, like, we can't explain this, but we're going to make sure that our rates are going back down. So you're still looking at that data to advise how you proceed, which I think is huge. So I'm going to pause for a moment to see if any of the attendees have any questions for any of our participants. Okay, well, I have one. Courtney, one thing I'm wondering about, and really anybody, is when you do case reviews, how do you conduct that review in a way that allows space to objectively step back and identify where the process could be improved? And how do you then operationalize that to action?
This is a great question. We have kind of just changed our practice where, because we're a small enough hospital, our denominator is pretty small every month. And so at OB committee, we have talked about, Dr. Stefka talked about just culture, and we use that at our hospital. And every single time I'm communicating it with my staff or my providers, like, listen, we want to do better for our patients, and we want to make sure we have safe moms and safe babies. This is not to point fingers. This isn't to say anybody did anything wrong or call anyone out. This is about learning, hey, here's what happened. Here's what we could do differently. And let's all get on board and see how we could do this different. And so it started, and this has been a couple of years in the making of changing our culture and accepting that we're all on one team and we're all here for our patients and our babies. And so that's kind of where we started. And I remind everybody every month before we even start these cases. And so I bring all of our nulliparous C-sections that went for the month, and we might look at the strips and review the strips so that the docs can talk about, here's what I was doing, here's what I was thinking. And my docs are really good about asking the other ones, what do you think about this? And what would you have done? And then are also great about telling me, here's the phone calls I was getting from nursing, or here's what I saw that nursing was or wasn't doing. And then bringing that conversation back around to my staff, like, okay, hey, here's where we identified, here's what happened, and here's what we should be doing or what we could do differently. And I think if you can establish that culture, that just culture, it goes over well.
Courtney, this is really phenomenal work that you guys have done. And as you pointed out throughout your presentation, you and your team have really incorporated a lot of the ideas that we talked about and many of the tools. And I think it's just a great example of how it can be done. It's hard, and changing mentality and establishing this just culture and the review process, I think it's hard. It's exceedingly hard, and it takes time. At Denver Health, when we started a review process for not necessarily cesareans, but any near misses or sentinel events, it was a good, I want to say, 2-3 years before we had provider buy-in, and 4 or 5 years until providers and staff, nursing, whoever's, students started reporting their own cases and coming to us, to the QI team, asking for a review. And that felt really great. It was a big win for us. Like, we finally got, we're getting there, but it, as you pointed out, it takes time.
It does. And we actually use, we've implemented this just culture hospital wide, and we use what we call Midas. I don't know if anyone else uses that, but we encourage all staff to put in a event, or, for us to review processes or what happened and what we could do differently. Because once you remind staff, a lot of this stuff is process based. It's not individually based. And so, again, just like you said, it's that constant communication and that constant talk of just reminding everybody. And once you do that and you can get everyone on board and you change that culture, it really just fell into place for us.
Thank you. We have a question in the chat. So is there a form or guideline that anyone has that helps specifically with case reviews? So one of the biggest struggles we have is actually doing the case review, not really an RCA, but more discussing the case, discussing the outcomes. Is there a format that's helpful for that?
I got to be honest, I don't have a specific form, but I would be interested in one as well. I, as a director, just go through every single chart, but I have a small denominator, and I will go through and kind of look at what happened, what I can identify from the charting from the providers and nursing staff, and then bring it and talk about it. But I would be interested as well. Dr. Sefka, Sarah, do you guys have anything or know of anything?
We don't, but I think this is a great idea, and I think maybe the SOAR committee can come up with something. I imagine part of that form will probably include the shoulder or the dystocia, the labor dystocia checklist, since those are some of the major points, but also can certainly include maternal demographics and then neonatal and maternal outcomes. So days in hospital, blood loss, infection, transfusion, so forth, ABGARs, cord gases, things like this. So I think, Val, maybe we can work on an example and provide to those who are interested.
Yeah, I think that's a great idea. And just to pop in, going back to, it's gonna take me too long to find. I have thrown in this obstetric event debrief form as an example. This obviously is thinking about an obstetric event, but maybe something along this format could be used for specifically looking at NTSV cesareans. And so I think it's a great idea for the SOAR committee to develop that and provide it as a resource to tool. And somebody previously asked for a reference for this. This is from the California Maternal Care Quality Collaborative, CMQCC. And I'm happy to send a copy of this form out with the recording from this meeting.
Yeah, definitely having on that case review, definitely having a section on kind of reasons for the primary, or final problems identified, or whatever needs to be addressed. A section that addresses problems with the case will be helpful. Yeah, this is the brief form that I think Denver Health adopted from the CMQCC. I think maybe slightly modified to reflect kind of our team composition, but I think the two are very similar. Yeah.
Great, thank you. So we are at time. So thank you all so much for joining us today. And thank you again to our panelists for sharing. I think these tools and resources and experiences are invaluable for other teams to learn. So as a reminder, please fill out our evaluation survey that will pop up after you exit the webinar. And have a beautiful weekend. Thank you, everyone.